Hello, I'm David Cromwell. I'm a Professor of Health Services Research at the London School of Hygiene and Tropical Medicine. I'm also the Director of the Clinical Effectiveness Unit here at the Royal College of Surgeons of England.
So first of all, what is the Clinical Effectiveness Unit and why is it giving a home to NatCan?
Well, the Clinical Effectiveness Unit has been at the college for 25 years. It's a collaboration between the London School of Hygiene and the Royal College, and we aim to undertake national studies into the performance of surgical services in the NHS and provide information to them to improve the quality of the care that they give. One of the features of it is that when we set up a national clinical audit is we make sure that we have a multidisciplinary team of senior clinicians, junior doctors, methodologists like myself and statisticians, and working together we make sure that we answer important questions in a way that's robust. It's very easy to have a very large data set and analyse it in ways that produce information that's no use to anybody. By having the combination of the clinical expertise and the statistical expertise, we're able to hopefully provide information that will support and promote quality improvement.
Audits are obviously quite complex, they require a lot of data. How do they help?
The national studies are important because they provide a complete picture of practice in the NHS. So you can contrast whether the care being delivered in London is the same as, say, in the southwest or around Newcastle, and providing a way of describing the patterns in the country allows people in, say, Newcastle to ensure that the care there is being delivered is of the same standard, or they can learn lessons from other organisations.
And how have audits changed in terms of the way you collect data has become more sophisticated? How has that made the audits more effective over the years?
When I started doing audits about 20 years ago, what we were asking hospitals to do was to collect data for us, and they would fill in paper forms, and it was not always clear that we would be getting all the data from everybody, and some of the forms weren't necessarily completed completely. Over the years, what we've been able to do is link more to national data sets, and these are much more complete. So they may not provide the richness that we might require, but they do allow us to identify all the patients with a particular condition who you'd like to be part of the audit. And we're often able to link specifically designed clinical data sets to those national routine data sets to provide us with a very rich picture and allows us to examine care in fine detail. Some of the performance standards that you want to know about may be for particular patients. So in breast cancer, you might want to know the stage of the disease, how far it's spread, and that will then, because the treatment decisions will be linked to the type of the cancer and the spread of the cancer. So having that information allows us to then provide information in a very refined way back to surgeons and other parts of their team to judge whether the care that they're delivering is in fact meeting the published standards.
People sometimes find it a bit uncomfortable to be just seen as another point of data. So how do the kind of large-scale clinical assessments you do translate into specific help for individual patients?
The important things that we provide is a summary of how well an organisation might do in general. Now, every patient's care pathway will be slightly different, and that's important, but there will be a kind of typical pattern that you are able to pull out when you're analysing the data. So one of the areas might be in vascular surgery. Patients may come with a problem with the flow of blood in their legs, which is quite a serious problem and can lead to, say, an amputation. So surgeons and other vascular specialists will want to go in and remove the blockage or improve the flow as quickly as they can. And by providing information on the kind of pattern of waiting times or delays from presentation to surgery across a whole group of patients, it allows them to refine the process that makes sure that individual patients aren't experiencing delays.
Presumably individual audits can learn from each other. And so one of the points of having a national cancer collaborating centre is that one type of cancer audit can learn from another and again produce outcomes which make more people better more quickly.
Oh, definitely. The process of improving audits has been continual over my career, and we're going to continue and bringing all the audits together is going to give us an opportunity to make sure that we learn from each other. The care pathways and the types of treatments that get delivered in, say, prostate cancer are related to, but quite different from patients with lung cancer. But there are ways in which we can make sure that the way in which we display the information back to clinicians and patients and the way that we analyse it are rigorous and learn lessons from one audit to the other.